Today on TLC Live, type 2 diabetes and obesity in Latinos, challenges and opportunities. We're going to have Dr. Elizabeth Vaughan. She's Associate Professor of Medicine with a primary role as a physician science at the University of Texas Medical Branch in Galveston. Good morning, everybody, and welcome to TLC Live. As every Wednesday, I'm Andrea Gomez. Orlando Sanchez is in a special assignment, so today I'm going to be solo with the doctor. So good morning, Dr. Vaughan. Thanks for making the time to be with us and talk about this important topic, not only for the Latino community, but for everybody, for every community that it's at risk in diabetes or already having diabetes. This is one of like a pandemic or epidemic that we've been suffering, and I think every year is it's even more the way that the lifestyle, the way that the people are, or the companies are making the food, and we live like all the time in a rush, in a very fast life. So we don't take care of us, especially the Latino community. So welcome to TLC Live. And
Thank
I
you.
wanted you to start with telling us a little bit about you and your background.
Well, thank you. Thank you so much for having me. It's a pleasure to be here today. So as you mentioned, I am at University of Texas Medical Branch in Galveston. I started working with the Latino population when I was in high school. I went to Ecuador and I learned that speaking Spanish was a real thing. It wasn't just a Spanish class. And I really fell in love with the Latino population, the culture, the warmth. And I actually started speaking Spanish so I can finally speak, 20 years later. So I became initially a dietitian, and I went to Guatemala and I spent the summer there. And I looked, and there were so many needs, and I thought, nutrition is needed here, but it's so much more. And I really wanted to practice more than just the GI track, essentially. So I did finish my dietetics. I went to Mayo Clinic, finished an internship, and said, well, what next? And so I ended up going to medical school. I became a primary care physician. I spent most of my career, the last decade, at Baylor College of Medicine, and now I'm in Galveston. I've been mainly a researcher in diabetes and the Latino population. A lot of the population we work with, and probably most of it, is uninsured, and that creates a myriad of problems. How do we get our pills? How do we get doctor's appointments? How do we get access to care? And it's not a wonder why diabetes is such a problem in Latino populations when so many suffer from other social determinants of health. And so that really, to me, was an intriguing question. How do we help this population in particular? For the individuals who are Latinos who are dependent on manual labor, diabetes is I compare it to cancer in a sense. Cancer is a terrible disease. If you're told you have stage 4 cancer, it depends on what cancer that is, but it can be a fatal sentence. Diabetes can also be a fatal sentence,
Mm.
and but it's preventable, and all of it, for the most part, can be prevented with our diet, with our lifestyle, with following our medications, our prescriptions. It's preventable. And in the Latino population, particularly those who are dependent on manual labor, the complications are devastating. Working years at Bentop Hospital, and seeing individuals who have amputations, who are on dialysis, who have lost their eyesight, and the list goes on and on. Basically, wherever there's an artery, diabetes can affect it.
So,
And that's so sad to see that. And so
so
that's where
Dr.
I've
Vaughn,
invested my career. Yeah.
the increase in the percentage of the amount of people in the Latino community that is been suffering from type 2 diabetes, it has to do with genetics, or it has to do with education, or is a combination of both?
It's a great question. And even our smartest people in the world don't totally know why everyone gets diabetes. But we know obesity is a major link to diabetes. Maybe take a step back. What is diabetes? We kind of assume that we all know, but what is it, and what happens? So just as kind of a A quick step, either we eat sugar, and when we eat food, all of our food turns into sugar, whether it's sugar, or whether it's fat, it all turns into sugar in some way or another. And insulin is a hormone, and that's responsible for getting the sugar into our cells. It's kind of I'll have little diagrams I'll show patients with a person with holding a box of sugar, and that's insulin, and pushes it into the cells. Sometimes insulin can't do that, and it's called insulin resistance, or insulin is not able to do. There's no insulin, period. When there's no insulin, that's what we call type 1 diabetes, and that's about 10% of our population. That's it's quite uncommon. To this day, we don't know what causes type 1 diabetes. That was what we used to call childhood diabetes. Type 2 diabetes has some sort of insulin resistance, and that's where your question went, is, why, what is it that causes this? Insulin resistance, we know it's associated with family history, less physical activity, and certainly obesity and being overweight. I often show patients a picture of insulin trying to put sugar in the cells and a big blockade between the two. And then I erase it and I say that's called weight loss. And so I'm oversimplifying, a very complicated mechanism, but that's really what happens. And when people lose weight, we see their sugar levels drop to the point a lot of times they don't even need the pills that they were taking. Sometimes a lot of insulin, a lot of pills, they get to a normal weight, they don't even require it.
But not necessarily, because I know people that they're not overweight and they
You're
still
right.
have type 2 diabetes.
You're right. Exactly. And that's why it gets so complicated. The vast majority of individuals with type 2 diabetes are overweight or obese, but you're exactly right. And that's the mystery. Why do people who, and particularly we see with some of our Southeast Asian individuals, that they're extremely thin, sometimes underweight, and yet they get type 2 diabetes. And those are really the mysteries. And we, and the individuals say, man, what do we do differently in this population when you can't lose weight and they're already physically active? And someone those individuals is more like a type 1 where you can't change it. But the vast majority of individuals who are overweight and obese, those are the individuals that we can move the mark of decreasing diabetes.
And when we say Latinos, it's we're talking about Latinos in United States, or we're talking Latinos in all Latin America. This problem is in this country, or this problem is in all Latin America. Because I'm from Colombia, and I don't remember. I grew up over there, and I came to this country when I was 25 years old. I don't
Mhm.
remember hearing about type 2 diabetes back then. I never heard about type 2 diabetes in kids. I've been
Mhm.
hearing about this in this country and with a certain community. So, put it as in perspective, the problem is the type of the food in United States. The problem is the communities in United States, or the problem is along all Latin America.
Yeah. So in the U.S. Latin American population, about 17% of individuals have diabetes, and that's compared to 8% of white. So there's definitely something in the Latino population. And when we look at that something, we look at sometimes the weight. I was astounded. I looked up weight statistics. I thought, what is the prevalence right now of overweight and obesity? In the Latino population, 80% are either overweight or obese, compared to 70% of non-Hispanic individuals. So is this a U.S. problem, or is this happening in the rest of the world? Your story is very similar to a lot of individuals. I didn't hear about this in my country. Why am I hearing about this now? Is it McDonald's down the street? Is it something in the air and the water? We're seeing this interesting in a lot of countries, a lot of developing and developed nations, as they're becoming more industrialized. Kenya is a great example. In Nairobi, individuals are starting to get desk jobs, and they don't need to be out in the fields and with the cows, and they're less this farm life, more urbanization, and the weight is increasing, the physical activity is decreasing. And what we'll see as well with Latinos when they come to the US, their diet changes. No more is it, having foods that were cooked. Then they sit down and have meals. It could be more fast food. the obesity in children. The children are not running around and having hills to play on. They're sometimes in schools with little activity. Sometimes we don't have physical education. So the activity levels of children are significantly decreasing. So activity levels, diet, food, those all contribute to that one problem that keeps going to weight. Is it because someone eats a McDonald's hamburger? No, but what is it? With calories, it's calories in, calories out. And so whether it's a McDonald's hamburger or whether it's 5 hamburgers or whether it's broccoli, in the end, if your weight is not a healthy weight, that is the biggest risk factor for diabetes.
And also, I contribute this to the way that is the food industry is making the food. I mean, it's very with a lot of hormones, and the way that they're making the food these days is completely different. Back then, in my time, I mean, like I remember my mom used to go to the supermarket or the farmers market and buying every product, and it was organic. It was less processed. And here, not only that fast food industry, restaurants is everywhere, and especially in the low income communities, but
Mm-hmm.
also the low income communities don't have access to supermarkets. They don't have access to Whole Foods. They don't have access to regular supermarkets. But not only that, even if they have access to Whole Foods is super expensive for them. So I think it has to do with other aspects or facts that people are not getting the real food what they need to do. Also, the way that we live life in this country, parents have 2 3 jobs to feed the family, and so it's easier for them to get a McDonald's or to get a fast food as a $1 menu. I mean, things like that. It contribute to the problem that we're facing these days. And I never saw so many obesity kids in my life till I came to this country, and especially these days.
Yeah. Yeah. No, it's certainly our culture, drive-through dinners. It leans to a very different way of life, our stress levels. So a lot of the foods that are processed and prepared, they're very high on what's called the glycemic index. Glycemic index is, if you go, we always think of sugar is high. And, I go and I eat a big candy bar that's just plain sugar, not even a chocolate bar. That's going to be in my system within 15-30 minutes and then out within an hour. And I call it the vending machine cycle. It's 4 o'clock in the afternoon. I'm so hungry. I just need to get some. So you go get a Pop Tart, and that's pretty much all sugar. And then within 30 minutes, you feel great. And then you go back to your desk and you work. And then within an hour, you feel worse, and your sugar actually drops more than before. Foods, even white bread, white pasta, any white flour product, those are often higher. Even white rice, tortillas, are higher on the glycemic index than plain sugar is, meaning that those foods make you want more than you did before you even ate them. And so these pastas and a lot of the foods, and when you go to a lot of the prepared restaurants that have these processed foods, they have these foods that are very high on the glycemic index, and they make you want more, versus foods that you prepare at home are going to have different oils, different carbohydrates that make your body have a higher amount of satiety. You feel more full after you've eaten these foods. If you feel more full, you're less likely to eat more. And so certainly it's a vicious cycle. Busy lives, quicker food, bad food. And then I hate using the word bad. I when I tell my students there's no bad food, it's the portions that we have of that food. But it does
Especially
it,
in
it
Texas.
all becomes a cycle. I'm sorry.
Especially in Texas, the portions that everything is big in Texas. You go to any restaurant, you order a
Hmm.
salad, and the salad is huge. I mean,
Yeah.
everything here is big. Another ingredient that it's not good for what we're seeing is like the lack of health insurance, the lack of access to doctors, the lack of access to healthcare, prevent, so
Hmm.
education. And, these communities, the Latino communities, especially the immigrants that are like now what we're seeing with the border crisis, they're
Yeah.
crossing the border, they come to work, and they don't have access to anything.
Yeah. It's a major problem. One of the clinics I work at in the diabetes program, we asked the patients to check their sugars, and they said, well, they can't check them because they don't have glucometers. And I said, well, how do we expect individuals? And the clinic is, a great clinic, and they're trying to serve the poor. It's a free clinic, but they don't have the money to afford the glucometer to give to the patients. And I sat back. I said, well, how do we expect individuals to know their sugars, to know how they're doing, to manage their medications, which really can be quite dangerous. When I start someone on insulin, I want them measuring their sugars because it can be very dangerous. They can be very high, they can be very low. It's not a one size fits all, particularly with insulin. And individuals say, I can't afford it. I can't afford the glucometers. I can't afford the supplies. In one of the research studies I'm running right now, we look and see, if we put community health workers into the program, and then we train community health workers, make sure they know about diabetes, can we help the communication between the patient and the system? And in one of the studies, we were able to identify over 400 issues, and over 90% of those issues with the community health worker involved, they were able to not only identify, but also resolve. Most of those issues, access to care. I can't get an appointment. I can't get a medication. And these clinics are full.
Mhm.
And the great thing about having the community health workers, a lot of times the patients, they take up an appointment slot saying, oh, I just didn't know if I should take this pill once a day or twice a day. And we can help reduce the burden on clinics by having better communication systems like community health workers, like patient navigators. It's a major problem. If you don't have access to care, how do you care for yourself? How do you know you have diabetes? How do you know you have obesity? Or how do you know anything is wrong? Sometimes I'll see men particularly men, not to pick on men, but men in their 50s or 60s, and they'll be in the hospital admitted for something. And, they haven't been taking great care. They don't eat a great diet. They don't have physical exercise. Their weight's not good. And I say, do you have any health problems? And they, oh, no, 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 never had anything. I'm perfect. And I said, you don't see the doctor, do you? I said, that's what you call a male in his 50s or
Yeah.
60s with no health problem. It's a male who hasn't seen the doctor.
Uh-huh.
But how can individuals see the doctor if they don't have access, or if an appointment is hundreds of dollars? Medications are another major issue in diabetes. Of the 12 or so oral meds that we have in diabetes, 3 of them are low cost, meaning $4 a week and a month. Some patients can't even afford that. But the other ones, and there's all this great data on, heart, reducing heart complications, reducing renal failure, all these other medications. But I say, but they're 400 a month. It's 700 a month for one pill. And how do we get these to our patients? So until we reduce the cost of medications, it's very challenging. So right now with the 2 or 3 medications, that's how we manage them. Insulin is extremely expensive. Even the cheapest bottle of insulin costs about $25 at Walmart,
Mm.
in pH or regular. And that doesn't sound bad, but 25 can mean quite a bit for individuals. Most patients that are taking insulin, I'm usually prescribing about 5 bottles a month, sometimes more. 5 times 25, plus the syringes, plus the lancets, all the other supplies. They often spend $2,000-3,000 a year on supplies. So major, major, major issues. Even if we can get them in, we have to make sure they can get the supplies to take care of themselves.
So I think here it's to me the biggest problem or the biggest challenge I would say is educate the community to prevent, because once you get it, I mean, not only the it's so expensive, the medicine is so expensive to get access to the doctors, but
Mhm.
after that it's not only the problem of type 2 diabetes or just diabetes in general, the consequence of diabetes,
Mhm.
because with
Yeah.
that comes another disease, another health issues. So let's talk about that.
Yeah, absolutely. Prevention, particularly in Latino population, particularly in uninsured individuals, by far the most important. So, how do I prevent it? Well, the first thing is knowing your risk. So I encourage individuals, if you don't know what your BMI is, your body mass index, am I normal weight? Am I overweight? Am I obese? If you don't know it, jump online, jump on anything and just put BMI calculator. Put your height, put your weight, and not the weight you think you are, the weight that you actually saw on the
Yeah,
scale. Um, we often have fluctuant weights when we do our own weights.
yeah.
And so what's your BMI? And a lot of times, with the community health workers, I always tell them, if we're going to teach the population, that we have to own it ourselves. And so do you know your BMI? Do you know what your risk factors are? So along with risk factors, CDC has a great calculator. And for fun, I put in a bunch of risk factors. So I'll just list them off. There's about 7 risk factors. So your family history as a risk factor, anyone with diabetes, if you have high blood pressure. So I said I've got high blood pressure. Age over 40, you get a point. Age over 50, you get 2 points. Age over 60, you get 3 points. So I put I was 60 years old. Ethnicity, you get the most points if you are Native American, but Latino gives you several points as well. Low physical activity, if you're a man, and if you are obese, you get points. So the most points. So if I have a family history, I've got hypertension, I'm 60 years old, I am Hispanic, I'm not physical active, I'm a male, and I'm obese, I had a 10 out of 10 chance of getting diabetes. So knowing what your risk factors are as an individual person, that's an important thing for prevention. And then the third thing I'd say is going and getting checked. A lot of times there's health fairs, and so doing the simple glucose. For those who are pre-diabetic, having a glucometer costs you $10 at Walmart to have. Getting some Lancets, and they're $10 for Lancets, so you don't have to have a prescription. You just go and get them, and checking your sugars every once in a while. Check them once a while, and people don't like to poke themselves, so you can that's the one thing to get over, but you'll be poking yourselves a whole lot more if you get diabetes. But just a couple times a week, check it one time in the morning. In the morning, you should be between 80 and 100. Check it another day, a couple hours after you eat. You should never be over 200. If you're over 200, that means you have diabetes. In the morning, fasting without anything, that means that you are at 126 or higher. That means you have diabetes. And so know your risk factor. Go to the doctor, get your labs done. At least, if you're over 40, go every year. Get your labs done. How's your cholesterol? How's your weight? How's your blood pressure? Those are the number one things that an individual can do outside of keeping a healthy weight and physically active. Those are the main things an individual can do to prevent diabetes.
What do you think is the biggest challenge that you guys are facing, not only with the hospitals and the government and everything in general, for you guys to be able to get the community not only informed, but to serve the community?
The biggest challenge are finances. So individuals who don't have insurance, getting them connected, even individuals in the Harris County area, that a lot of times they have a gold card, 50% will often lose their gold card. And so keeping that communication. So an individual who doesn't speak English, who may or may not read or write, making sure that we are attaching individuals so they can get and stay connected to health systems. Um, Most providers have no idea what their patients face. Clinic is very busy, hospital is very busy. It's honestly been quite humbling for me to work with community health workers and see what my patients tell me on a Saturday in the clinic, and then tell the community health worker on a Monday. It's often very different. Particularly the Latino population, really wants to do well, and they want to say, yes, I'm doing everything. And a lot of times they don't want me to know the struggles of them doing those. So the communication, if I were to put my finger on one thing, what's the most important thing, I'd say communication, and ways to keep that communication door open between the patient and the health system.
So now let's talk about opportunities and what is being done, or what is the plan to try to solve this problem.
Well, Part of it is getting more funding to get cheaper meds for patients, and so getting our meds to be generic is a major hurdle. But once we do, that's going to open a lot of doors. Right now, there's something called PAP or patient assisted programs, and so they can get these really expensive diabetes meds that I mentioned, SGLT2 inhibitors, for instance, have showed great data, um, but they're 700 a month, and patients can't afford them. Right now, these programs help individuals to get them, but they are complicated. They require forms, they have to have renewals. And so, people will say, well, do you use the programs? I say, well, when I do, they're great, but there's a lot of problems with them. And so what's being done is and what needs to be done are simpler processes, allowing better communication, getting our medications generic, and so we can get more access, freeing up clinic spots, having more availability. Right now, Harris Health and Harris County, you've got a plethora of opportunity. There's documentations, there's always challenges, but you step a line outside of Harris County, and there's nothing there. So there's more and more free clinics that are opening their doors. They need support, and they need, whether it's volunteer or financial support, they're always in need. But those right now are the only opportunities and the main ways patients can get care outside the Harris County border. And so for the free clinics, we're really dependent on them, and opening their doors and having more funding and more availability.
So, call to action, where people can find information or access to programs or free programs or anything that it can help them to navigate these issues that we're facing.
Yeah, no, that's a great question. So, American Diabetes Association has a great website. It's got a lot of patient resources to say, am I at risk? What do I do if I'm at risk? What do I, who do I call? Harris Health is in the Harris County system, and on their website, there's oh gosh, when I worked there was 20 clinics, but now it's quite a bit more ambulatory clinics where individuals can get care if they live in the Harris County system. The CDC, the Center for Disease Control, they also have great information, particularly for Latinos, as far as what the risk is. And they have very patient friendly information where people can go and find information and find about their personal risk factors and what they can do.
And also the website that you sent us, what we can find there and what is the opportunities and programs.
So on the website I sent, mipromotor.org, that's our website. So we support community health workers, and we try to equip local individuals. We strongly believe that individuals from their community and raising up leaders from the community can be some of the best champions to help their community. No one knows diabetes in Latino more than someone who is Latino and from that community. And so our group primarily focuses on Latinos. Of course, it can be, scale to other diseases, other ethnicities, but we focus on Latinos and type 2 diabetes. And on the website, there's a lot of materials and videos for either patients that can watch if they have diabetes, anything from medication adherence to complications and how to reduce complications. And they're about 20-minute videos. It's a year-long course, but someone can take it in 12 days if they want to. We send one video per month. And it's to equip the community health workers. I want to become a community health worker. What do I do? How do I get certified through the state of Texas? And then what do I do? I'm certified, so how do I learn more about diabetes? And so it's to help educate individuals. We found that community health workers, they're the frontline individuals, but they're not medical, and they often have the least amount of training. And so we want to make sure they're equipped so that when they see patients and when they're in the community, they know how to answer questions and reduce patient harm and also enhance patient communication.
Let me, so Mark, do we have the website? So let's put the website that way people can recognize it and look for it.
And then our contact information is on the website. So if they want to contact us and have more
What
information,
what is the website?
mi promotor de salud,
I sent it to you
mi
in the
promotor de
email.
salud.org.
mipromotordesalud.org. It's on the email that I sent you. Promotor de salud.org.
There it is. You
Okay.
put them, and it's de
Mi
salud.
promotor, no, it's de salud.
Yeah, de
Yeah.
salud.
But
There you go.
okay, well, let's put it, okay, perfect. Mi promotor de salud.org.
There we go.
Okay, great. All right, Dr. Vaughan, thank you so much for your time. The message to the community.
Know your risk and do something about it. When you've done something about it, go help someone else.
Great. Thank you so much for your time. And definitely,
Thank
we
you.
need to work on prevention. That's the key.
Agree. Thanks so much. Really appreciate the time.
Thank you so much. And thank you so much for watching us. Remember that you can log into TexasLatinoConservatives.com, TexasLatinoConservatives.com, support our cause. Also, we have a lot of information, resources. And remember, if you have any question, you can send us an email. If you want to be part of TLC Live, you have a good topic and you're an expert on something, let us know. We can arrange for you to be on TLC Live to always give information, valuable information to the community. Also, remember, we have November's elections coming up. October 23rd, which is Monday, is going to be early voting, start early voting, and Elections Day is November 7th. Remember, it's very, very important. We have local elections. We're going to have the new mayor this coming November. We're going to elect city council members. We're going to elect the city controller. We're going to elect very, very important positions that impact our daily life. So if you are already registered to vote, do your homework, do your research, find the candidates, learn about them, and just go and vote for whoever identify with yourself and with your values. So thank you so much. Nos vemos el próximo miércoles. Chao, chao.